The second speaker that I'm really excited to introduce tonight is Dr. Sophie Plagakis. Goes back a few years when I met Sophie back at the Royal Adelaide, and then I met again, we worked together again with her at Flinders. A fantastic doctor, she's a urologist. If anyone was looking at the program on tonight, you may have seen that she's talking about prostate cancer again. I'm not good with my spell check. I should have sent it to my mother to have a look at, but no, she's not doing prostate cancer again, but had a fantastic talk last night. I think the men really enjoyed that topic. There was a few squirmy moments, I think, but it was a great talk. So Sophie works at Flinders Medical Centre as a staff specialist urologist and sees private patients through urological solutions. She looks after patients with general urological conditions such as blood in the urine, prostate cancer and kidney cancer, and also manages services for male and female patients with urinary incontinence in her private and public practice. I'm really excited about introducing Sophie tonight. She's going to have a wonderful talk, and please make her feel welcome.
Good evening, ladies. Thank you, Alice, so much for inviting us to come up for the weekend to Melrose. It's always a pleasure to come to the Mid North. And as I was saying to the guys last night, I actually did a bit of medical school in Clare. And the reason I became a urologist is because Kim Pacey, who I work with now, consults in Clare. And I sat in on this clinic and I thought, oh, this is the best job in the world. And here I am, 10, 15 years later, still doing it. So I guess I'll talk about a little bit of what I do for work, and then I'll just describe to you as well how, as women in the country, you might actually access our services, and perhaps if any of these issues ring true for you, you know how you might go about seeking some help. And I've got a few handouts that might be of interest to you as you leave tonight too. So I'm going to talk about incontinence in a broad sense, because what goes for women also goes for men, more or less. So it's really quite general. And then, of course, women's cancer and urology, because we all know about prostate cancer, and everyone knows about breast cancer, but you know, there are a lot of urological organs that women have as well that also have cancer in them at times. So it's important that you all know how to keep on top of your own health in that respect. And so a lot of women I see, and men, we talk about lower urinary tract symptoms, and we talk about storage symptoms, so you know, being able to hold urine in the bladder. So women and men might come in and say, look, I've got urgency, when I've got to go, I've got to go. I can't stop, you know, keying the door, walking through the freezer section at the supermarket, all those things will stimulate you in your bladder. Frequency, so going frequently, like quite often, and you know, every hour or so, every half hour, losing control in those moments. Waking up at night time. So if you wake up once or twice at night, that might be okay, especially if you're avoiding a good amount. But if you're getting up a few times and you're only going 50, 100 mils, and that's less than half a cup of your glasses, then that's abnormal. When you do go to the toilet, you might find that it's a bit of a stop-start or a weak stream, or you have to change position on the toilet seat in order to make it work. So that's a problem for some people. And then this is more for men, that they might dribble a bit. But for women, we might find that we don't empty very well. And something for us to keep in mind is that as you get older, your tissue's not quite as tight and taut as it used to be. And you might find that you've developed a prolapse. And sometimes that prolapse can be holding, sort of pocketing urine in it. So when you do go to the toilet, not everything comes out, you get stuck in this prolapse. So some women actually need to put their fingers in their vagina and push their bladder up in order to be able to pee, or push their fingers down to the rectum to help them empty the rectum. These are common problems, easily addressed, and often can be addressed without surgery. So that's what's important for you.
I see that a lot in my work as well, people needing to use their fingers to empty the rectum.
Yeah, it's very, very common and not talked about very much until you come and see the doctor. So this is just a bit of a schematic that they come up with. And the top one that I crossed off is prostate issues, because that doesn't apply to people in this room. And if it does, that's okay. But something that we don't talk very much about is detrusor underactivity. So the detrusor is the muscle of the bladder. And with women and men, as you get older, it doesn't work as well. We don't talk about it very much. We talk about overactivity. But actually it doesn't work as well. And if you've had a hysterectomy, when they do that hysterectomy, they might cut some of those microscopic nerves to the bladder that you can't see with the naked eye, or with the laparoscope or the robot or anything. And so women might come to me after they've had their hysterectomy a few years down the track and say, I've never quite peed the same. So that's something that's really, really common. So just that you're all aware of it, because I'd say a lot of the women that see me, that tends to be their problem. They say, look, 8 years ago I just stopped peeing right and I don't know why. But there are other things. So some people make more urine at night time. So they pee absolutely fine during the day, and at night they make more. They make double what they make during the day. That's a different problem. They might have pain. They might have had a stroke. And when you have a stroke, or if you have Parkinson's disease, it makes your bladder more sensitive. So you have trouble with your bladder because of that. Multiple sclerosis can also make your bladder more sensitive and can make your bladder a bit more lazy, so you don't empty your bladder very well. So there's lots of things that can go on. It's a really complicated system. And that's why it can be important to seek help early. There are other things like bladder tumours, urethral strictures, kidney stones that we can fix easily. That it's a good reason to come and see a doctor early, because if you've got one of those simple things, we can fix it. Your symptoms will go back to normal. So you see your GP, they run through a general checkup. So that might involve a bladder diary. It's exactly as boring as it sounds. It's a 3-day list of everything you drink and everything you pee and what time you do that. Urine tests to look for blood in the urine, to look for cancer cells, blood tests to make sure your kidneys are working well, an ultrasound to check your kidneys aren't blocked. And then sometimes you have to come and see me, and I might look inside your bladder with a camera, and I might even do some bladder tests. And I'll talk a bit about that later, just so you understand where that might fit into your treatment. So back to what I was saying, these are the things we can fix easily. So recurrent infections. Lots of women have a lot of urinary tract infections. It's one of the main things people see before. Some people have scarred urethras. They're a bit sort of tight. Kidney cancer, bladder cancer, they might have blood in their urine, and we've got to rule those things out. And bladder and kidney stones. The reason we want to fix incontinence, so if you leak a bit of urine, it might not bother you. As you get older, you might leak more urine. And what we find is that people who are incontinent or have urgency or go to the toilet a lot at night time, they're actually more prone to falls. And as you'd be aware, if you're older and you start to have falls, that actually impacts on your quality of life and your life expectancy. A lot of people die from a fall. My grandmother died from a fall. So we want to prevent it in elderly people because it prevents a lot of the complications that go around falls and ending up in nursing homes before you should. Also, going to the toilet more frequently is definitely linked with fractures. So people break their hip, they break their arm bones. And that can also send them in a nursing home earlier than they should be. And something that we should keep an eye on, more in men than women, is how much urine you hold in your bladder after you pee. Women can tolerate it more than men can. So men, they run into trouble and need catheters earlier. For women, what we find is that you probably get away with not emptying your bladder completely. But once women start to find you're getting recurrent urine infections, blood in their urine, bladder stones, and those are all reasons that they might actually need to learn to pass a catheter, or we might need to try a few things to make them pee better. This is really just a picture, just to show you that as your bladder becomes more stressed, it develops these little sacculations, we call them diverticuli. You can see the muscle gets thicker and thicker and thicker, and eventually that thickness of the muscle causes a back pressure on the kidney, and can cause a blockage of the kidney. So that's why it's important to nip these things in the bud. Women are more likely, in general, to have an overactive bladder. So that's the key in the door, got to rush to the toilet, wet myself, can't make it on time. And that's something that will happen with age and time. Men are more likely to have enlarged prostates, which can cause the same problem to them. So once the enlarged prostate gets to a certain point, it actually affects their bladder function and they have both issues. They can't pee, and when they do pee, it sort of goes everywhere. So we treat overactive bladder mostly with tablets. So this is a table that I use for my patients. And I've got some handouts at the front there. I don't expect anyone to take business cards or the pictures of myself. I'm not sure my secretary put them there because you're not going to drive to Adelaide to see me. But at the back of the sheets, and I've separated them for you, there's actually a copy of this table here. So if you're just to have a squeeze at it later, just grab one on your way out. And also please take the pens, they're really good pens. I don't want to take any home. So I've explained to patients that some people have stress incontinence, that's the link with cough, sneeze, jump. Some people have overactive bladder, that urgency frequency up all night. We myself can't make it to the toilet. The overactive bladder, there's a lot of first-line therapy we can do without tablets. And the most important thing, if you guys are in a rural area, the first person I would see after your GP has made sure that there's no signs of cancer in their ultrasound and urine test is the physiotherapist. There are pelvic floor physiotherapists. Nigel told me there's one in Jamestown, I think one in Peary. You want to see a women's health pelvic floor physiotherapist. They can actually sort out a lot of this for you. They can also usually fit pessaries. So if you have a prolapse, they'll diagnose the prolapse, they'll put the pessary in. You don't need to wait to see a gynaecologist. Not everyone's GP does it. So see the physiotherapist, they'll get you sorted. And once you get to a point with the physiotherapist where it's really not as much of an improvement as you like, then you can come to see us. And at least we know that all the basic stuff's been done and been done well. So overactive bladder, we tell everyone, stop smoking. If you're postmenopausal, start using vaginal estrogen cream. And that's safe even if you've had breast cancer, because it's just absorbed at the skin of the vagina, it doesn't go into your blood. Weight loss, avoiding irritants, so caffeine. We love caffeine, we love coffee, but it does make people's bladder go crazy. And then we add in tablets. Now my favourite tablet is something called Betmega. Unfortunately, it's $50 a month. It's expensive. But I tell patients, look, try it for a month or two. If it hasn't worked in those 2 months, then we know that it's not going to work for you. It has the least side effects. I like it in older people because it doesn't affect their brain, whereas the other tablets we've got affects their brain. So I try not to use that as much as I can. And then we go to third-line therapies. The physio, they can actually do a little bit of this. They can do some of the acupuncture. Have you heard of TEMS machines? Who's got a TEMS machine? Yeah, they're really common. And a pelvic floor physio can actually teach you how to use your TEMS machine to stimulate the tibial nerve at your ankle. Now what happens is the nerve leaves your back at the S3 nerve root. It goes to your bladder, and then from your bladder it shoots off down to your ankle. And if you stimulate it down at the ankle, it actually sends all of these impulses back up via the bladder into your spine. And for some people, that can work really well at controlling overactive bladder. You can do that at home. So there's all these little tips and tricks that you can tap into in your local area. If the tablets don't work, then people come and see me. And I might do Botox into their bladder, so instead of putting it into your forehead, put it into your bladder. And the other treatment I have, the other surgical treatment I have is actually a pacemaker, and I'll talk a bit more about that in a tick. Stress incontinence, there are surgical and non-surgical treatments. Pelvic floor physio will sort you out for the non-surgical treatments. There might be a pessary. There's all these devices that are not pessaries as such for prolapse, but they're little rings with knobs that you can put in the vagina that, for example, if you're only leak when you're playing netball and you only want to sort things out when you're playing netball, you might just put that in while you're playing netball. And then once you've finished your game, you take it out and you get on with your life. You don't have a surgery, you don't have an irreversible treatment, you just have a solution for a particular activity. But surgical options, which I'll talk about very briefly, include bulking agents, slings, sphincters, and also a little sort of stitch that the gynaecologist can put in with the keyhole surgery. But the bulking agents, think fillers. Instead of a filler in the lips, I put a filler in the urethra just to give you a bit more resistance. Lasts about a year. Reversible. So this is the tibial nerve stimulation. So we can do it in the clinic. You've got to drive to Adelaide every week for 6 weeks. I don't think anyone's going to do that, but you might be able to do it at home. And that's the TEMS machine. This is the pacemaker. So there's a little pacemaker device that we can put in the back that will give this constant stimulation, this electrical stimulation down your S3 nerve root. And that's a good treatment for overactive bladder. It works in about 70% of people. But it can also treat those women who can't pee very well, so what we call non-obstructive retention. So sometimes we have these young people who might have had a spinal cord injury or some issue in their youth, they can't pee, they need to use catheters to empty their bladder, and this will really fix things for them. The beauty of this treatment is that we do a trial phase. In the trial phase, you have a bit of sedation, we put in a little needle into your back, we send you home with a little wire that's taped to your back, and you stay at home for 7 days, you don't shower, you sponge bath, and it trials the treatment. And then you come back to my clinic and I'll pull it out in the clinic, you don't need another anaesthetic. And if it worked for you, then we say, okay, great, that worked. Let's think about, are you happy to have a pacemaker? If it didn't work, then we know it didn't work. But it's a really, I think it's not so much low risk. It is low risk. It's just a needle in the back. There are very few complications. It's a trial. I think it's a really acceptable and easy way to try something that's a little bit scary. No one wants a pacemaker if they don't know if it's going to work. But it's a way that we can trial a treatment that previously was very difficult to sell to people. Stress incontinence, this is the filler. As you can see, those little blue dots are the bits that kind of bulk up the urethra. I actually have a young lady who's just had her first child, and she's been incontinent since that first child, and despite everything the physios have done with her, she's not quite right. She's going to have more kids. So we've actually gone for a bulking agent for her, because ultimately she's going to need something more permanent, but who knows what the subsequent pregnancy is going to do to her pelvic floor. So we've gone for a bulking agent, and we'll just monitor things. She can get that topped up every year until she's ready for something more permanent. And then we've got the slings. There's the mesh sling, and there's fascial slings. And fascial means a piece of your own tissue that we use and we put in that configuration to just hold up and compress the urethra. Any questions? So what's our goal? As urologists, as doctors, we just want to get you to a point that you're comfortable, that you can get on with your activities of your daily life, whatever you need to do. It's a very different conversation that I have with someone who's a gym junkie and works as a personal trainer compared to someone who's in their 60s or 70s, looking after grandkids, running around after grandkids. It's different. Everyone has a different goal. And certainly around the issues of mesh and fillers, everyone also has these preconceived ideas about what they're happy to have in their body. So it's an individual discussion with patients. So let's say, for example, you think, yeah, I've got this issue, I'm seeing the pelvic floor physio in Jamestown, it's not working, I need to come down to Adelaide and see someone. There's a couple of urologists who will do this work. And for most of us, I'd say that if you wanted to make an appointment to see us, being country people, we'd try and see you on the same day and do any tests that you need all on the same day. So when women have seen the physio and they're ready to talk about the next step, I do a cystoscopy, or other inside your bladder with a little camera just to check internally that everything's okay. And then I do a pressure test where I put a little catheter in your bladder and a little one in the vagina, and I fill your bladder with fluid, and I measure the pressure so I can see how much incontinence you have from column A versus column B. And then we can work out what the best treatment is, because most women will actually have a bit of both. And you want to treat one before you treat the other. So that's about an hour, 2-hour appointment that you'd have down in Adelaide in order to sort that out. And you come out of that appointment with a treatment plan from there. So that's it for incontinence. That was a Cook's tour. Whirlwind, my apologies. Take the hand out home and have a read of it. Women's cancers, this is the last slide. These are the 3 that we see. Ureteric cancer is really rare. Bladder cancer is not very rare. Bladder cancer is quite common in smokers, 6 times more common in smokers than it is in non-smokers. So it is quite common in the Australian population. It presents with blood in your urine. So if you see a show of blood and you don't have a urinary tract infection, then you need to see a GP to get a CT scan and come to see me for a cystoscopy. You can get a cystoscopy in Clare with Kimpizzi, you can get one in Port Pirie, you can get one in Port Augusta, you can get one in Whyalla. So we do a lot of these tests locally. And for people with kidney cancer, it's one of those things that we used to find when people had blood in their urine. It was this massive cancer because it has to get to a certain size in order to leak blood. But nowadays, because people are getting a CT scan for lots of different reasons, we're diagnosing them just by chance. People will have no symptoms. And of all my cancers that I work with on a daily basis, this is probably the best one to get because it's contained in a special pocket in the tummy. It's away from everything else. It has to get to a really big size to be a problem. We can often just shave it off or remove it in part and keep the rest of the kidney. So it tends to be something that we find by chance. And so people are always very shocked and very upset when they see us and need to have treatment. But in many patients, it will be curative and they never need to think about it again. And that's me done. Thank you for your attention. Any questions?
What made you choose that topic?
That topic?
To work with?
Well, incontinence, when we train as urologists, we don't see that much of it because you can imagine the amount of cancer work that goes into the public system. It just overwhelms all of this stuff. And so we don't get a chance to really work with it. But then when you finish your training and you're a woman in the urology field, well, there's lots of women patients, and a lot of female patients, I think, prefer to see a woman sometimes. So I think it's become one of those things, it's become a big part of my practice just by chance. And it's a lovely way to help people, but I must say, it is a much more stressful thing to deal with than cancer. Because cancer has to come out. You know, cancer has to be sorted. You've got a goal. You can't argue around it. But if something goes wrong with this surgery, then it's really, as a doctor, you just feel terrible that you've done something or you've given someone a treatment, and things don't go to plan all the time. Surgery is surgery. So there's a lot riding on it. So it's a very important thing that I do. It's not the easiest part of my job, but it's an important service to offer.
One thing. I see one of your first line management was bladder retraining. What are your thoughts around when people or patients have catheters and doing a flip flow bladder training to get the catheter out? Does that work? Or
when people have a catheter, it would usually be because they can't empty their bladder for some reason. The safest way for them to empty their bladder is to learn to pass catheter themselves, because then the bladder mimics the normal activities. The bladder is supposed to be the storage vessel. So it has to fill, it has to send your brain a signal that you need to pee, and then it needs to be able to empty. If you can't empty, then you either need a catheter in or you pass a catheter every time you need to use it. I think that the flip flow gives the bladder the better chance of maintaining its function. And for those who don't know, a flip flow is a little valve, like a tap, that we put on the end of a catheter that you can turn on and off. So instead of having this tube coming out of your bladder strapped to a bag on your leg, you have a tap on the end of that tube. So your bladder will fill when you get this sort of signal that you need to pee. So you can go to the toilet and you can open the tap and you can drain your bladder into the toilet. And that just maintains function. So where I can, I try to encourage people to do that. I've got a lady at the moment who's had a catheter in for 30 years, and no one ever explained to her that she should have a valve on it. Open, close, open, close. And this bladder's become this contracted, tiny little thing. So every time her catheter blocks, she's in agony. She has no capacity for that bladder to stretch. It's become this little calcified ball. And we really have no choice now but to give her a new bladder made out of bowel so that she can have a stoma bag, because the complications just from this catheter, it's not cancer, but she's going to need a major surgery just to get some quality of life back. So flip flow if you can, I think is ideal. Thank you very much, ladies. Enjoy the rest of the evening.
Thank you very much, Sophie. That was another wonderful presentation, and I'm sure we've got a lot out of it. I'm sure there's going to be lots of talk in the next 5 minutes. And Sophie and her husband Simon will be talking to us later in the evening. They're doing a bit of a tag team process. They've got 2 beautiful twin daughters. So I'm going to give thanks Sophie again tonight, just before she leaves, and give her a small token to say thank you. But yeah, please give her another round of applause. We'll have another quick 5-minute break before we get on to the third.